Welcome to today's webinar, Labor Shortages and Costs, Healthcare Finance's Big Challenge. This is Ashley Becker, HFMA's Client Services Specialist, and I will be moderating today's session. Now, it is my pleasure to welcome today's speakers. Chris Borgeson is the Vice President of Operations at Schneider Regional Medical Center. Chris entered the C-suite in April of 2020 and was immediately faced with the head-on challenges the pandemic caused his organization and the healthcare industry overall. Chris has over 15 years of experience working and managing in the healthcare field. Pamela Gallagher is the founder and CEO of Gallagher's Resulting LLC. Pamela is a senior financial executive with a 20-plus year successful record of instilling financial discipline, streamlining processes to maximize revenue, and reduce expense for the immediate improvements and long-term results. Simon Lukey is the Director of Professional Services at Harris Affinity Decision Support. Simon has more than 15 years of experience and leads a team of healthcare decision support experts who provide expert solution implementation, outsourcing, and business consulting services to more than 200 hospitals. Ralph Burns is a Senior Solution Engineering Manager at Harris Affinity Decision Support. Formerly a Senior Business Data Analyst and Cost Accountant at Cooper Medical Center, Ralph is an educator, mentor, and consultant with more than 35 years of experience in the field of business intelligence and management accounting. With that, Ralph, I'll turn the presentation over to you.
Thank you very much, Ashley. Appreciate those introductions. So first, I consider it a privilege to serve as moderator of today's event. And we have three amazing presenters who will each be delivering their stories and unique perspectives related to our current labor shortages and cost challenges. Now, before proceeding, on behalf of the entire Harris Affinity team, we would just like to acknowledge today's audience and all the members of our healthcare community for your good work, dedication, and commitment to supporting critical administrative and financial functions. As you perform an important part in guiding the process of delivering efficient, effective, and high-quality care to those in need, ensuring the health and well-being of the people and communities that we serve. Now, health finance teams serve their organizations and communities by providing leadership and guidance in navigating a seemingly endless list of challenges. Today's event is going to highlight some details about our current labor shortage and cost challenges, and offer some thought-provoking ideas that will assist you in your work. We are going to deliver this in 4 parts. The first part, we'll set a backdrop by providing an understanding of current conditions and challenges. The second part is a unique story about one organization's complex journey through these challenges. Then, we will unfold some of the details of this topic as seen through the eyes of finance. And the final part will focus on an approach to a solution. So without further ado, let's get started. I would like to introduce our first presenter, who is Simon Lukey from Harris Affinity. And Simon is going to set the stage for today's event. So please join me in welcoming Simon. Oh, my bad. I have a polling question in here. Simon, my apologies. Before we get started with your presentation, we have our first polling question, and it is this. What do you feel the Great Resignation is most closely linked to? Low pay, burnout due to unrealistic work productivity expectations, organizations not providing the flexibility employees need, for example, remote work options, or lack of recognition from managers and executives. So we'll give about 30 to 40 seconds here for you to respond to that question. And while we're waiting for that, Simon, let me just check with you before you get started there with this question. Do you have any thoughts on this yourself?
It's a good question, Ralph. So, I think that it's a combination of these factors. I'm very interested to see, what our attendees have to say about it, and what their perspective is on what is most closely linked to Great Resignation. There it is, 62% burnout.
I find that especially interesting, realizing that the audience who's taking the survey, we're part of this group. We're part of it. All right, so thank you. That was the first survey question. And now, Simon, if you would please go ahead and get us started. Thank you.
Thank you, Ralph, for that introduction. So healthcare labor shortages have been predicted for years. Even before the COVID-19 pandemic, the delivery of healthcare had been extensively analyzed, and potential labor shortages were identified as a future risk to healthcare organizations. The pandemic further exposed the weaknesses of current healthcare delivery and the impact of labor shortages, with significant consequences. Now, today's healthcare labor shortages are a combination of several different factors, and we just heard that from our attendees today that burnout is one of the major factors. So thank you for your responses. It's very interesting to see those. Also, illness, including family members, and decisions to retire or leave healthcare for other opportunities. Now, in a recent survey, 22% of nurses indicated they may actually leave their current nursing positions within the next year. We all know labor shortages have an impact on patient care. Analysis shows that nursing shortages have a direct impact on patient outcomes and thereby the cost of healthcare. The studies show that reduced nursing to patient ratios result in adverse events such as pressure wounds, falls, and hospital-acquired infections. Now, multiple studies cited by the New England Journal of Medicine offer a clearer picture of the pandemic's impact on patient safety and infection control. And that picture is not pretty. When the COVID-19 pandemic began, metrics tracking healthcare-associated infections and other complications of care indicate significant deterioration of multiple patient safety measures, according to an analysis published on February 12th by the New England Journal of Medicine. Central line-associated bloodstream infections in U.S. hospitals had previously decreased by 31% in the 5 years preceding the pandemic. However, this trend was almost totally reversed by a 28% increase in the second quarter of 2020 when compared with the second quarter of 2019. There was also a 43% increase in catheter-associated urinary tract infections, as well as a 44% increase in methicillin-resistant Staphylococcus aureus bacteremia. Skilled nursing facilities saw rates of falls causing major injury increase by 17.4%, and rates of pressure ulcers increased by 41.8%. As well, hospitals are also delaying or reducing healthcare services because of labor shortages. There remains a strain on healthcare due to the pandemic pressures, and therefore the delivery of healthcare for the backlog of these delayed services. Healthcare labor strategies are going to have to address more than just compensation. Health systems and other employers of nurses recognize this challenge and are actively designing and deploying new strategies. New care delivery models are needed to retain and attract nurses and provide improved work environments with flexible scheduling, coordinated care, and the expansion of virtual care. Developing strategies to create scheduling flexibility is going to be critical. A recent nursing survey indicated that nurses who experienced more flexibility in scheduling during the pandemic were highly interested in retaining that flexibility going forward. And for those nurses who indicated plans to stay in their current direct patient care role, flexibility in hours and shifts was an influential factor. Integrated technology is needed for these new care models. As you're all probably aware, use of virtual visits increased significantly as a result of the pandemic. The survey found that more than 40% of frontline nurses have delivered virtual care within the last year. with highest rates reported by nurses practicing in ambulatory and home care settings. 2/3 of frontline nurses are interested in providing virtual care in the future. This offers a workforce alternative for nurses. It may be particularly appealing for nurses struggling with physical demands of the direct in-person care who are evaluating whether they want to leave the workforce. Seamless communication needs to be integrated in our healthcare systems. We all know the delivery of healthcare is fragmented, and the results are high cost and utilization, and also often poor outcomes, particularly with the chronic diseases. Patients with complex care needs receive healthcare through a variety of providers at various sites, which often don't have seamless communications. The delivery of care needs to address integration of technology, such as better communication systems, as well as virtual visits and telemedicine. So, are current healthcare delivery models sustainable? The current healthcare delivery models that rely on hospitals need to change. A shift of where and how care is delivered must be assessed, and new models, such as community-based care and integration of virtual visits, needs to be adopted. These could reduce the pressures and dependency on healthcare delivery in hospitals. Extensive studies on healthcare delivery models, such as community-based, clinical-based, and value-based, as well as vertical and horizontal organizational models, show that when applied to healthcare, a combination of different models would increase the effectiveness of the care models. To meet patients' needs and align with organizational cultures, healthcare professionals, including physicians, should be engaged to become leaders of integrated care teams who focus on designing new care model strategies. Next, I'd like to share a case study. The country of Israel demonstrated successful delivery of both community-based and virtual care during the pandemic. The community-based healthcare system reduced the pressures of the pandemic at the hospitals. Citizens and medical staff were infected by the highly contagious Omicron variant. However, the hospital did not feel the pressures of the pandemic as were experienced in other countries. Israel has one of the strongest community medicine infrastructures in the world. The community-based healthcare providers acted as the triage and have been successful at keeping patients out of hospitals while giving them a range of services at home. This has kept Israel's fatality rates modest despite high infection levels. Now, the healthcare providers or health maintenance organizations, HMOs, have huge networks of clinics, and in response to the pandemic, have also offered an increase in telemedicine and online medical services. They also utilize sophisticated digital record keeping to manage vaccine effectiveness. The HMOs are the front line in the defense against the threat of the coronavirus. In the community-based model, HMOs try everything possible to have patients fully recovered at home, and they have successfully kept patients out of hospitals during the pandemic. The hospitals play a vital role in the management of those who are in serious condition, but the majority of Omicron patients are managed by their primary care physicians in the community. The strong community-based health system is one of the ways Israel is able to spend less of its GDP on health. Now I'd like to turn it back over to our moderator, Ralph, to introduce our next presenter with a unique perspective on labor costs and staff shortages at his hospital. Ralph?
Thank you very much, Simon. You have set a perfect backdrop for us to continue with this story. Real quick, there were two parts of your presentation that stood out for me. The point that healthcare labor shortages were predicted and the integral part that technology will play in supporting new care models. Now, before we transition to our next speaker, we have our next survey question. And the next question for the survey is this. Are there discussions in your organization on adding monetary incentives to aid in recruitment and retention of staff, such as referral bonuses, compensation increases, and student loan payment? And the options to respond to this, the first one is yes. My organization is currently looking at implementing added incentives. No, my organization is not currently looking at adding incentives. And then the third option, adding compensation incentives will not fix the problem. So we'll give you a little bit of time to respond to that. And then we will queue up our next speaker. Oh, and there we go. We have the response. Oh my goodness. I'm absolutely tickled to see this response. Yes, my organization is currently looking. That tells me that this audience is on the ball. You guys realize there are challenges and you're addressing them. That's fantastic. All right. Moving on to the next section of our presentation, I would like to introduce Chris. Chris Borgeson. He's from Schneider Regional Medical Center. They're located on St. Thomas Island in the U.S. Virgin Islands. Chris is going to share their unique experiences of the past few years, the impact they've had on their labor resources, and how they have managed and continue to manage these challenges. So please join me in extending a warm welcome to Chris. Chris?
Thank you for that introduction, Ralph, and good afternoon, everyone. And thank you for allowing me to share my organization's journey over the last several years with how we dealt and are dealing with raising labor costs and staff shortages. Over the last few years, I have done my best to take an optimistic or glass half full approach to these issues that are facing all of us in the healthcare industry. But first, let me tell you a little bit about my organization. Schneider Regional Medical Center is a integrated health system comprised of three entities: the Royal Schneider Hospital on St. Thomas, the Myra Keaton Smith Community Health Center on St. John, and the Charlotte Kilman Cancer Institute on St. Thomas. We serve three islands: St. Thomas, St. John, and Water Island. But you may be asking yourself, where is the U.S. Virgin Islands? If you squint, you will see that dot at the bottom of the red arrow. That is the U.S. Virgin Islands. The U.S. Virgin Islands are a group of Caribbean islands that make up part of the Leeward Islands. We are approximately 70 miles east of Puerto Rico, 1,100 miles south of Miami, 1,600 miles south of New York City, and 4 miles from Seattle. Due to this isolated location, costs associated with supply chain of goods and services raises overall prices on the island, making it one of the highest costs of living in the U.S. SRMC is accredited through the Joint Commission and certified by CMS. We have a very well-equipped hospital and offer several specialty services. But with these services, it also means having well-trained and qualified clinical staff. Besides our isolated location, other key areas that directly affect the financials of SRMC are the following. SRMC payer mix is 75% Medicare and Medicaid. We have multiple collective bargaining agreements within the organization. As mentioned, one of the highest cost of living in the US. We are reimbursed under the Tax Equity and Fiscal Responsibility Act of 1982, or TEFRA, and not DRGs. These TEFRA rates have not been rebased for close to 3 decades, even though the cost of doing business has. Currently, requests to CMS, the Department of the Interior, and to the US Congress are still pending. As you have seen, my organization already faced a number of challenges, both logistically and financially, regarding staffing. However, SRMC labor and staffing challenges did not begin with a pandemic, but with hurricanes. Hurricane Irma on September 6, 2017, and Hurricane Maria on September 19, 2017, were 2 Category 5 hurricanes that directly hit the VI within 13 days period. I'm very proud to share that during those 2 catastrophic events, we never shut our doors. Hurricane Irma at the time was the largest and strongest hurricane ever recorded in the Atlantic, with max sustained winds of 180 miles per hour. The picture on the upper right shows the nurses station on our 4th floor medical unit, where one of the hurricane windows failed. We did have patients on the unit at that time, and I'm happy to report that they were all safely evacuated to lower floors due to our heroic staff. The picture on the upper left shows the absolute power of these storms. This is a picture of an air handler where you can see that the sheet metal was literally peeled back like a banana. I personally had no power for 100 days and had no cable or Wi-Fi for over a year, which translated to a lot of Yahtzee by candlelight. Here are just a fraction of some of the other images showing the devastation and emergency efforts following these two storms. So this is where my story begins with staffing shortages. By the end of 2017, just 3 months after the storms, SRMC saw a 34.4% staff turnover rate. Some examples of this that directly affected me as VPO included half of my rehab services department left within days of Irma, and a quarter of my respiratory therapy service department separated by the end of that year. How do we manage? Patient volumes had significantly dropped due to the mass exodus of people leaving the island, federal funding, and unfortunately, layoffs in non-clinical areas. So as my organization was still rebuilding our staffing numbers and infrastructure from the storms, COVID hit. Between calendar year 2020 and 2021, SRMC saw another significant jump in staff turnover from 8.3 to nearly 15%. The main reason for separation included burnout, as that poll showed, mandatory vaccine mandate that was initiated, and clinical staff leaving for higher paying jobs and contracts on the mainland. So as the pandemic raged on, SRMC, like many other healthcare organizations across the country, had to rely more on staffing agency companies to support their staffing limitations. This increase in demand caused bill rates to skyrocket for these highly sought after individuals. My organization saw the following between 2020 and 2022 in our bill rates. We saw a 75% increase for nurses, 45% increase for medical technologists, and 32% increase for respiratory and radiology services. These increased rates and inflated salaries were being seen all over the country, especially in COVID hotspots. Here are a few examples of what I was seeing in the market at that time. In September of 2021, there was an advertising for a traveler respiratory therapist for a 12-week contract in Maine for $4,300 a week. Now, I know I have a lot of finance people in the audience today, but to break that down further, that is $107 an hour or $223,000 a year. A VA hospital in Cleveland was advertising for a staff respiratory therapist with a starting salary of $98,000 to $128,000 based on experience. The Bureau of Labor and Statistics listed the median salary for a respiratory therapist is only $62,000 in May of 2020. So very large jumps. Based on everything you have seen about SRMC, with its location, logistical and financial challenges, the rising cost of support staff, the overall pandemic, and still trying to rebuild from 2 Category 5 hurricanes, you may be asking, how is a small community health system in the middle of the Caribbean going to compete? Well, as this illustration shows, there were moments of feeling of overwhelmment, but my organization and I still had a job to do. And it all started with communication, both internally and externally. Internally, I had open and frequent discussions, sometimes multiple times a day with my CFO and finance department. I was lucky that at that time, my CFO was right next door where she may or may not heard my muffled cries. But what I also learned at this time and continued to believe in, it's not being annoying, but being persistent when it comes to this communication and frequent with others. I also began to share data with my finance department and senior leadership on service lines that were seeing jumps in volumes and potential revenues that was being brought on by the pandemic. These included pulmonary function test, cardiopulmonary rehab services, monoclonal antibody infusions, inpatient COVID admissions, and COVID testing, a lot of COVID testing. However, having empirical data is critical to painting an accurate picture so knee-jerk reactions do not occur, or to limit them at best. Some other methods for dealing with staff shortage internally. We reached out to retired employees or individuals who may have separated to offer independent short-term contracts. We begin to offer referral bonuses to staff who are referring potential candidates. And we contract with foreign staffing agencies for allied health personnel with work visa programs. And I'm pleased to report that currently we have 2 or 3 Filipino medical technologists that are working for the organization, and that is going extremely well. We're currently in discussions of offering daycare services, and we're working with our local government to earmark funds for additional funding for retention and recruitment initiatives. Along with internal communication, I found that external communication and working directly with these staffing agencies were beneficial to getting the cheapest rate. I did this by focusing on the positives and not the negatives my organization and the territory had to offer. I began selling the organization and the VI to potential travelers who would come for decreased rates. These included sharing our low COVID numbers both within the organization and in the community. My slogan at the time was, "Come work in paradise." This worked better in the winter months. And targeting allied health personnel that needed to get away from high COVID areas. After all that has occurred in the last several years, I remain optimistic that our industry will make it through this and will be better for it on the other side. I would like to close with a quote from Colin Powell that pretty much sums it up for me. And that is, the best method of overcoming obstacles is the team method. Thank you for your time and attention today.
Thank you very much, Chris. I tell you, I'm in awe of your hospital's glass half full attitude in facing challenges, especially in the light of the fact that St. Thomas has at times been referred to as a pebble in the ocean. In the shadow of hurricanes, pandemics, it looks as though the value that you place on communication and information have served you well. So thank you for sharing that with us. And now it is time for the next polling question. And let me read this one. The question is this: what do you anticipate the overall agency and or temporary worker percentage to change in your organization by the end of 2022? This includes all categories of workers: clinical, non-clinical, managerial. And the choices for this poll are as follows. The first one, no change. The second, increase by less than 5%. Increase between 5% and 10%. And the final choice, increase by 10% or greater. And Chris, based on what you just shared with us, how do you see this poll? How do you see the responses to this poll?
I'm going to say, just based on my personal experience, Ralph, what's going on is I'm going to say that there's going to be no change currently. See what they say.
Okay.
Ooh, close.
Okay. Whoa. This is close.
Into the wire.
This is close. The greater than 10% versus the no change kind of split the difference, but then it's pretty much packed in the middle there between less than 5% or somewhere between 5 and 10. All right. Okay. Thank you. All right. And now it's time for our next presenter. And now we're going to move on to the finance perspective. And our presenter is Pam Gallagher of Gallagher's Resulting. Having served as a CFO for several hospitals throughout the U.S., Pam is going to share some key topics that are of particular interest to anyone who is working in the current climate of healthcare administration. So please join me in welcoming Pam.
Thank you, Ralph. And I just had to say, I had the privilege of working with Chris through some of the most recent staffing challenges he had, and he's just a wonderful person to work with. I just wanted to do a quick selective view on the current labor crisis from a finance perspective. So what is happening? While the current staffing crisis or labor shortage may seem like a new problem for some of us, it is not entirely unprecedented. We have faced many of these challenges before. Previous shortages, primarily in nursing, have been addressed by a variety of initiatives. Things such as federal funding for nursing education. There were changes in licensing requirements. New categories were added, such as nursing aides and various tech positions. Wages were increased. Some of these programs actually helped with staffing, even during the COVID pandemic. Multi-state licensing programs continued to expand. There was emergency licensing. Wages were increased again. And other funding, including bonuses and hazard pay, was used. This was just not enough to stabilize the staffing in the industry. Shortages have escalated, and indications are that the labor situation is not getting any better, even with some of the declines in the number of COVID patients. Now, the beginning of the current labor shortage was not immediately recognized. During the early days of COVID, there were drops in volumes that left many employees with limited or no work. Then there was funding made available to hospitals to get ready for the increase in patients, so the financial impact was delayed or masked. There's so many issues. Some of them are familiar. If it was only the supply of nurses and wage issues, why can't we just expand current programs of education and increase wages? One issue that is unique to the current shortage is the retirement of baby boomers. Less supply coming up as the demand for nursing and hospital services increases. Now, there's a great article by Nick Hutt in the January 2022 HFMA publication that has more information about this specific challenge. It's a good read. What else is new is the scope and the breadth of shortages that are impacting the entire traditional healthcare labor force. Now, Ralph Burns, who's part of this presentation, says the healthcare entity is a collection of industries. All of the industries are being impacted, not just nursing, all services within healthcare. But the most unique and significant labor factor I see is the competition for labor outside of the traditional healthcare environment, and not just for the non-clinical positions. These are some of the competitors that are hiring clinical. Walmart alone hired more than 5,500 pharmacists and pharmacy managers and over 13,000 pharmacy technicians last year. Dollar General just hired a chief medical officer. Meta, formerly Facebook, is hiring for lab managers for their VR labs. That's tough to compete with. And of course, anything as a service. We're familiar with software as a service, and in healthcare, we have seen the expansion in coding and revenue cycle services and management, providing services as needed. Sometimes the same hospital employees are now employed by a service company and often performing the same or similar tasks. Now, these services are continuing to expand in things like accounting, costing, supply chain, environmental, almost every area. Clinical services are expanding with agencies providing those services. Now, remember, as those service entities hire, there's a draw from the traditional healthcare labor or talent pool. So competition is fierce. And here's a newsflash. Healthcare leaders need to make quick, informed decisions to effectively manage. Informed decision-making is critical to successfully competing and even surviving as the industry changes. Now, we have massive amounts of data, and we need to be able to use it. Remember, the data has to be valid, accurate, reliable, and available. So just a quick mention on the importance of making sure that the data is usable. Data governance is needed to ensure that the data being used to provide information is correct. If not, it is going to cost you. Now, here's an example of some of the costs of inaccurate data. So once appropriate validation processes are in place, then the data should be usable. Now, on to using the data. This is my favorite part. You have to know where you are in order to know where you're going. You have to evaluate your current operations, strategically review current operating models, Provide information on scenarios, the what ifs, such as changing hours of operations, changing in staffing models, changes in locations, including remote versus on-site. You need to target solutions to specific organization or areas. Examine non-clinical areas too. Determine staffing to meet actual needs. Automate when financially beneficial. You have to know the cost first. Analyze the cost of using outside services versus internal resources. Really look at remote services. Will the increase in technology costs be offset by the reduction in other expenses, such as cleaning, rent, insurance? There's also the added potential benefit for an expanded labor and talent pool using those remote and contracted services. Implement meaningful metrics, not just counting FTEs, metrics to measure outcomes you have selected. Determine what you really need. Can you use a slice of expertise? For example, and a lot of us are doing this already, it's cost reporting services, taxes, decision support, budgeting, accounting. You may get expert services or even become one of the service experts. Remembering that we are in healthcare and evaluating operations and identifying the amount of support needed is often key to maintaining services and not reducing services in other areas. Not every service that has a negative return can be eliminated or even reduced. Now, here's just some parting thoughts and some things to think about. We all have to work together, and COVID has made it so much more difficult. However, there's some great resources to help us. Check out the HFMA forums. The No Surprises Act is a forum, it's an excellent way to keep in touch and be informed. Keep an open mind. Highlight some initiatives. Really appreciate your time in attending this presentation and all the colleagues that helped me gather information for this. But now you're going to get a chance to hear from Simon, who will share some excellent information on implementing solutions for the labor crisis.
Thank you very much, Pam. Very much appreciated that. And there was one part of your presentation where you identified companies like Google, CVS, and Walmart that are a growing part of the healthcare delivery landscape. And it highlighted for me how the competitive rules of engagement are changing. They are profitable companies, and they have robust information infrastructures. I believe the traditional healthcare delivery organizations, they're going to need to assess their enterprise decision support systems, and that they're going to have to make sure they're up to the task of competing in the new landscape. So I very much appreciate what you shared there, and the picture that you painted is quite accurate. So, all right, spot on, exactly. So now we're going to moving on to the final chapter of the presentations today, and this here, I guess, it's what Alfred Hitchcock might have referred to as the thrilling conclusion, the part of where the mystery is solved. And for this, please join me in welcoming Simon back to the screen as he wraps it all up in one neat package. Take it away, Simon.
Thank you, Ralph. So before we jump into talking about solutions to solve the labor shortages, one thing that Pam mentioned just now, I want to talk about again, is the high cost of incomplete or inaccurate data. Activity-based costing, or ABC, probably something you've heard of. I hope something everybody has heard of. It is the industry standard, as it is the most precise and the most accurate method. So a little bit later, just want you to be thinking ahead. We're going to have a polling question about your organization's shift to activity-based costing, or ABC. So with new approaches that provide integration, including virtual work models, healthcare organizations will be able to design coordinated and flexible healthcare environments to retain and attract healthcare resources. To develop new approaches, you're going to have to take a look across your entire workforce to find where you can change workflow and care delivery or deploy technology more effectively. Now you have an opportunity to reinvent new care delivery models, reinvent your work environment with more flexible scheduling, integrate technology by taking advantage of virtual care and improved communication methods with other healthcare providers. Also, discuss replacement strategies. Now, your first step is going to be to assess your organization. As Pam mentioned, healthcare is rich in data, and this data should guide the design of new approaches, especially ones that leverage decision support data, since that is the single source of clinical resource utilization and financial data. conduct a labor assessment, look at your nursing labor requirements, low to high nursing care for all of your different services provided at your hospitals. But don't forget to look at other labor besides just nursing, your lab, your diagnostic imaging, your allied health. Consider the volume of services and the amount of labor time needed to provide those services. And then you'll be able to assess the ability to transition to virtual care or other care providers. Don't forget to look at a revenue and cost impact of doing those different shifts. Conduct a labor shortage impact. Look at your patient safety and assess how the adverse events will increase costs for your hospital. Those adverse events, of course, including hospital-acquired infections, pressure wounds, and falls. Now, the graph on the next slide shows how one hospital used their activity-based costing data to help them understand how their nursing staff was being utilized during the peak months of the pandemic. So let's look at this analysis that highlights volume and labor variances across inpatient care. Again, like many healthcare organizations, this hospital also suffered from severe labor shortages during the pandemic. In fact, one of the key decision support resources at this facility, who happened to have a nursing background, had to be reallocated so that 75% of her time was spent doing OR prep work, leaving the remaining 25% of her time to continue providing decision support services. So this facility was obviously suffering from that nursing staff issue. Using the decision support data, this graph was created to help this hospital understand what services required the highest nursing labor per case. This information is then used to help inform decisions on what types of services may be reduced or outsourced, as well as understanding what type of nursing skill set was required when hiring new nursing staff. The graph shows the top 10 inpatient services based on total nursing labor. Now that it appears blue to me, but it's on other screens, it's kind of bluish green. That blue-green bar represents the case percentage based on volume of cases per service divided by the volume of all inpatient cases. And that gray bar represents the labor cost percentage based on the labor cost per service divided by the total labor cost of all inpatient cases. Since nursing labor cost is a direct indicator of nursing workload, we can extrapolate that discrepancies in the two bars illustrate services that have a higher than average nursing labor requirement when the gray labor percentage bar is higher than the blue-green case volume percentage, as well as services that have a lower than average nursing labor requirement when the case volume percentage is higher than the labor percentage. Now, this graph clearly indicates that the alcohol and drug use and mental disorder service, the respiratory system service, and the nervous system service have a high nursing labor requirement per case. This provides the hospital with that low-hanging fruit, so to speak, as they now understand that their focus needs to be on these three services. The focus of today's presentation is all about labor staff, so we won't go into details regarding the next steps of this analysis, but from a high level, I wanted to mention decision support data should then be used to conduct a profitability assessment to help understand how profitable each service is and therefore what impact a case reduction on a particular service would have in profitability. Now on the next slide, we can see where the hospital conducted a similar analysis on the ambulatory patient data. Again, the decision support data was used to identify the top 10 ambulatory services based on nursing labor. The ambulatory services with the highest nursing labor requirement per case are clearly day surgery, outpatient mental health, and the diabetes clinic. Again, this provides the hospital with areas of focus. Could we increase our telehealth services for diabetes and or outpatient mental health patients? During peak pandemic times, could we reduce the number of elective day surgery procedures? Of course, this information that we've seen on these last two slides is very unique to one healthcare organization's labor situation. Now, if we go back and think about Chris's story regarding labor shortages during a hurricane, I think that's probably perhaps the most obvious reminder to all of us that each healthcare organization has its own unique set of challenges, and there is no single solution. Unique challenges require unique solutions. So I'll leave you with this final thought. Like this hospital, you have to look to your own decision support data to help you make informed labor decisions given your own unique situation. And I'll give it back to Ralph now to wrap it up. Thanks.
Thank you, Simon. I'll tell you, the approach to the solution that you presented, for me anyway, it fits perfectly with the challenges that were defined in Chris and Pam's presentations: communications and the value of systems that deliver information that is defined in a way that fits the challenge. Okay, so before we move on to the Q&A, we have our final polling question. And let's put that up on the screen here. And the polling question is this, as Simon indicated as a prefix to his presentation: has your organization moved toward activity-based costing, ABC, to get a more precise idea of the true cost of services to justify staffing needs based on efficiency and effectiveness? Three simple choices for this one. It's either yes, no, or unsure. So Simon, before the answers are put in and shared, what is your gut feeling on this one? Where do you think it's going to land?
Well, Ralph, I think we're seeing a slow but definite shift in U.S. healthcare organizations. Activity-based costing is nothing new to our neighbors to the north. We've worked with Canadian hospitals for decades with activity-based costing. So I'm hoping that we're going to see a lot of yeses here. Great. That's
the results.
That's fantastic. That to see 42%. Of course, love to see that at 100%. But
yeah, the response to this that catches my attention is unsure. And for myself, I would view that as a very honest answer. A very honest answer, unsure. But it's also nice to see that it's split pretty evenly between the three of them. That the yeses and the nos, with the yeses just by a little bit, topping everything else at 42%. Okay. All right. Let me just put this out of the way. All right. So before we move on to the Q&A section of today's event, I would just like to first say thank you to the HFMA for hosting this event. I would like to say thank you to you, the audience. We appreciate your time that you have shared with us today. And I would also like to thank our presenters, Simon, Chris, and Pam, for sharing their experience and knowledge with us. And now I'd like to turn it back over to our host for the Q&A session. So Ashley, if you would be so kind as to let us know what sort of inquiries have we received about this information.
Thank you, Ralph. And thank you to all of our speakers for that engaging presentation. I would just like to remind the attendees to enter your questions in the Q&A box located on your computer screens. So the first question that we received is, do you get any questions about raises in relation to CPI inflation? For example, I'm getting a 3.5% raise when CPI is 8.8%.
Now, might I be so bold as to direct that question to the finance person on the panel, Pam?
Those are all negotiable, and things have not settled yet for us to make any type of determinations like that. It is a discussion item, but then again, if the raises are higher than some of that, sometimes we don't take it back. I think we'd have to wait for things to settle a little bit now before we make those things. And wages have been increasing in some areas by more than that, as Chris pointed out. So I think we just have to wait for a little bit of settlement first before we can make across the board any type of ties to the current CPI.
Chris and Simon, did you have anything to add to that?
I think Pam answered that perfectly.
Okay.
Next question. What are examples of activities in your nursing ABC models?
Simon, I'm thinking that one will fall on you.
Sure. Yeah, I'd love to take that one, Ralph. So we have worked with different organizations that collect their nursing workload at different levels, as detailed as being able to track minutes spent on assisting patients with bathing, specimen collection for lab tests, So those would be the examples of activities that we use to help capture all of the nursing activities that would be used for activity-based costing. So I hope that answers the question.
Thanks, Simon. This question is for Chris. With communication as a key part of your solution, what are your sources of information for those conversations?
Thank you for that question. So it's gone back and forth. Like there was moments, as Pam mentioned, when we worked together when the time was of the essence, so to speak. So we had to do things, as I mentioned in my presentation, just knee jerk. Again, our main objective here is patient care. So we had to make sure that we needed what we needed for staffing numbers to make sure that was being done safely. But on the flip side to that is we're coming off the pandemic, and kind of going back to what Simon's presentation was really looking at those numbers and get a better idea of the data. So when you sit down to the table, whether it be the boardroom, across from a colleague, and you have those discussions, that have some data to help guide that communication, right? Data is not the hear-all, but it can definitely help steer that conversation so decisions can be made for the best of the organization and what you're trying to do.
Chris? Another question related to ABC. I would like to hear more about ABC specifically from the perspective of a small independent hospital. It's very expensive and time extensive to implement. Have any small hospitals implemented this?
So I'll go ahead and jump right into that question, if that's all right with the rest of the panel. So to answer that question, yes, absolutely. We've worked with a number of small community hospitals in the past. I think the record is probably a 15-bed hospital that we worked with that has successfully implemented case costing. So there's no limit to the size of hospital. No hospital too big or too small to use activity-based costing and can realize the benefits of implementing activity-based costing. So there's the heavy liftings on the front end, and then after that, a lot of the process is pretty straightforward. So it's not something that is limited just to the larger hospitals at all.
Next question is for Pam. Where do you see the overall state of healthcare with these significant changes, especially regarding staffing?
I think we're all going to be, no matter what company you're in, it's no longer going to be traditional healthcare. I think the whole, all the market's going to have some type of healthcare. You can work for Google, Walmart, and be part of healthcare. And I think the traditional healthcare is going to almost be disbanded as we grow. We'll be more partners with a lot of folks, like Simon had mentioned, community-based and things like that. I think healthcare is going to be everywhere. It's just not your local hospital. Healthcare is going to be permeated with every industry and every organization. I don't see this traditional state healthcare organizations being long-term solutions.
And I think we have time for one more question. When adjusting productivity metrics for nursing and clinical-based areas, should an organization incorporate recent pandemic-impacted volumes or staffing shortages, or look at solely pre-pandemic levels, such as 2019?
I'd like to tie into Simon on that one, where he had mentioned evaluating and what you can use some of this current nursing staffing for it and things like that. If you tied into there what you actually need, I think you can be better prepared for those. Because healthcare is not static, even the ED. But some of the things that Simon mentioned absolutely would help solve some of those issues. So you could actually hire better.
And we do have time for another question to Simon. When implementing solutions for these challenges, sometimes the solutions themselves can be a challenge. What is your recommendation for choosing and implementing a solution?
So again, I go back to, I think the most important part of implementing a solution is one that is flexible and has the ability to do activity-based costing. It is the industry standard for cost allocation. The traditional charge-based costing, there are multiple publications out there that say that charge-based costing is just not going to cut it anymore for the decision making that our healthcare organizations are going to need to make. So number one priority when choosing a solution is the ability to do activity-based costing.
Thank you. Do any of our speakers have any closing remarks before we sign off here?
I just wanted to add on to what Simon said there, and I got the chance to meet him through this process. And he's very cognizant of the cost to the, like you said, the independent hospitals, and also the flexibility, like he mentioned there, that is key because one size does not fit all. And as you said, the solution. So I have a new appreciation for some of the tools and things after this. So, and thank you, Ashley.
All right. And with that, we have reached the conclusion of today's webinar. I would like to thank our speakers for presenting and Harris Affinity for sponsoring. We hope you have found the presentation informative. Thank you for your participation and have a great day.